technology in the vascular technology program here, just like Neil and Leah that have spoken before. I do tend to speak fast, so please, I'm looking at the chat, and if anybody needs me to slow down or go back and look at another slide, I'm more than happy to do so. But we'll get started here. So, carotid disease. That's what we're going to be speaking about today. That's what I'm going to be speaking about. So, our objectives, where we're going over vascular anatomy, making sure that we understand, what we're looking at, waveform analysis, which for me is big when it comes to carotid ultrasound. And then pathology and stenosis criteria, specifically what's the updated criteria from IAC here in the United States, and then application of the waveform. So we'll do a little bit of kind of case studies, just to kind of try to apply what I was learning and maybe throw in some kinks here so that we can start discussing and thinking about different things that may come up while we're scanning, and then abnormal waveforms that are without carotid disease. So obviously we can get some abnormal waveforms from the heart, and they can look a little funky. That doesn't mean that there's carotid disease sometimes. So just to understand a little bit more about that as we get going here. So first thing about, carotid exams is we want an indication, right? So why are we doing the exam? One thing that I like to reiterate to everybody is that we are treating patients, not pictures. And what I find really important about that is that, one, listen to your patient, get a good history, get a good physical. Not only does that help you in the exam itself and understand why the patient is here, but it may actually, the patient might be felt like they're heard for the first time too. I think that that's really important. A lot of times, and we all do it, when we're in the hospital, we have busy jobs and everything, but, sometimes if we listen to the patient and the patient feels heard, we can get positive feedback from the patient as well. So as one of my old professors would say, I'll get off my soapbox and we'll get back to the slides here. So carotid bruit, right? So that could be an indication for the exam. No stroke or stroke symptoms, transient ischemic attack, screening prior to surgery, and then follow-up of known disease or after intervention. So just because they have disease doesn't mean that they have an intervention here. So the probe that we're normally going to be using, Leah talked about it a little bit in her first slide, and Neil did it as well, is that linear probe, linear transducer around the 7 megahertz. Might change a little bit depending on the machine that you use, but right there with the linear transducer, we're going to position the patient supine with the head turned away from the side being examined. One thing that I notice sometimes with some bigger patients is that, sometimes their neck can get a little bit scrunched. And so taking the pillow away, opening up the neck area there can help with the exams. So you can be facing the patient and facing the patient. What I mean by that, right, is that their head is to your right here, and their feet are below you. So that would be facing the patient, or you can do it where their head is facing you, right? And you can kind of scan one way here and then the other way here. This can help with ergonomics. I worked in Boise. We called this the Boise backhand. It's not always feasible just because when you are scanning inpatients, it's not, you have tons of wires. You don't always have room to move the bed. But sometimes with the outpatients, this can be helpful for ergonomics. Neil talked about that a little bit, with the venous insufficiency exams, ergonomics. And so that can be an important part of making sure that you're staying healthy. So just, if you ever get the chance to try that maneuver, try it out. So vascular anatomy here. So we have our common carotid artery, and right, we're focusing on the extracranial circulation, so not the intracranial circulation, but the extracranial circulation. So common carotid artery, And then we have our external carotid artery and internal carotid artery. I'll be using a lot like CCA, ECA, ICA as far as the acronyms for my lecture here. So a couple things to remember about the anatomy, right, is that the right common carotid artery comes off the brachiocephalic artery or the innominate artery, and the left common carotid artery comes off of the arch. Important factors here, just remember with subclavian steel, so we'll talk about that a little bit later, but just remember that the right common carotid doesn't come directly off the arch, and that you can have some issues with the brachiocephalic artery on the right side that are causing issues to both the common carotid and the subclavian, and not just the common carotid or the subclavian, which would be the left side. So bifurcation is at about the level of the superior border of the thyroid cartilage here. But it's important to note when you're scanning that where the bifurcation is, and this can help with carotid endarterectomies, especially when they're cutting down. If you note that bifurcation is a little bit higher than normal, that can help the vascular surgeon understand, okay, well, this cut may not be as easy as I thought it would be. So maybe we have to go a different route as far as surgery goes. So just a couple things to keep in mind there. So there we go. Okay. So when we're scanning common carotid artery, right, it's going to be visible with the internal jugular vein as well. So that can be helpful when trying to find the carotid artery, especially if it's occluded or it's calcified or something like that. Find the internal jugular vein, and that can help identify the common carotid artery and transverse. And then we have our carotid bifurcation here. So we have our internal and external carotid arteries. Just to note, right, the external carotid artery is going to show up a little bit anterior than the internal carotid artery. So on this picture here on the carotid bifurcation, most likely looking at the left side, where the internal carotid artery is slightly bigger than the external carotid artery. Not always the case, but that would be my guess when we're looking at this picture. So just some things to note, trying to differentiate between the external and the internal carotid artery. I always find it helpful when we're trying to identify arteries that if you're having issues long axis wise, always just go right back into transverse, and it'll help you get more of a global picture of that internal external carotid artery or wherever you're at in the body, if it's the SFA or wherever. So then we have our carotid bifurcation here. This is a really good long axis picture. You won't always get this. Maybe in 5% of the patients you'll actually get this picture of the carotid bifurcation, right? So you have your ICA, you have your ECA, and you have your common carotid artery. Just when you're scanning, right, noting that with the external, it's going to be a little bit anterior. So if you kind of fan your probe anterior-wise, you should get the external. If you fan posterior, you should get the internal. And then we have our vertebral artery, which is on the right side of the screen there. So when we're scanning the common carotid artery, knowing that our vertebral artery is posterior to the common carotid artery, so just fanning a little bit posterior, okay? So not going as high as the bifurcation with the ECA, ICA, right? Coming down, finding just that common carotid artery and long axis and fanning posterior. So waveform for the carotid artery, spectral waveform. Common carotid artery is going to have that intermediate kind of low resistive flow. So we're going to have some end diastolic presence, not quite as much as the ICA, where the ICA is very low resistive, feeding, our organ, the brain here. And then our end diastolic flow presence in that ICA, which is higher than the CCA and the ECA, right? And then the ECA is going to have very similar waveform, maybe even slightly less end diastolic presence with the ECA compared to that CCA. The CCA is still feeding right? It's feeding not only where the ECA is, but it's feeding the ICA as well. So it's going to have a little higher resistance or a little lower resistance than the ECA, but the ECA is going to still have some end diastolic presence to it. So again, here's our normal kind of carotid, common carotid waveform here. Still's low resistance, normal upstroke, spectral window. So right, we're making sure that Doppler is right in the middle of the vessel so that we get a nice clean spectral window, and it's about 1/3 of the vessel, the gate. So we want to be picking up just the velocities kind of right in the center of the stream there. And also important to remember the vascular bed we are feeding. So the ICA, right, feeding the brain, the ECA feeding the face, the facial muscle. So the face doesn't need as much blood flow all the time as the brain. And so that's kind of, my thought process, how to differentiate those. So differentiating ICA from ECA can be a little tricky at times. So there's a couple, different things we'll talk about here. Transverse ICA is typically larger, like I talked about earlier, and it's more lateral than the ECA. So in long axis, the transducer is pointed medial toward the face for the ECA. So, right, what I was talking about earlier, right, is that we're going to fan kind of towards the face. We're going to fan kind of towards the back of the head to get the ICA there in long axis. So the bulb location, so the bulb is not always as prominent on some people, and it may be a little bit different. So it's not always conclusive for the ICA, but it can help you if you're looking at that as well. Color Doppler. So if we're in transverse, we have color Doppler on, that ECA is going to be more kind of pulsatile because of that higher resistance, whereas the ICA is going to be more persistent with color. It's going to be more constant with color. And that's that low resistive flow. That's that flow all the way through diastole that we're talking about. So that can help differentiate the two when we simply just put color on in transverse. Pulse wave Doppler. The ICA is, like we said, lower resistance, so it's going to have more end diastolic presence, whereas the ECA is a little higher resistance. And the flow is similar in each vessel. We can do the temporal tap or the temporal oscillation of both the vessels. So that's putting a waveform in, or our Doppler in, and looking at the waveform to see kind of if we're getting that ECA, that tap, which is the ECA, right, is feeding the superficial temporal artery, which therefore we're tapping, and we would see that in the waveform. So let's look at that waveform and what that temporal tap would look like here in the ECA picture. So temporal tap, tapping anterior and slightly superior to the ear, okay? So we're going to be tapping kind of right above where, the glasses would go, the glass hand would go right there. So you tap it, and the oscillations within the ECA waveform you can see on the picture there. And this is very helpful, especially when the ICA is occluded. So the ECA, the brain is one of the most important organs in the body, right? So there's a lot of collateral flow that happens within the brain itself. You can see the circle of Willis right above me right here. So that's that collateral flow, right? The ECA can actually, what we call, internalize. And so it can become lower resistant and look exactly like the ICA if the ICA is occluded. And the ECA is the one that is providing that collateral flow. When this happens, it can be really hard to differentiate between the ICA and the ECA. So a temporal tap can be very, very helpful. Highly suggest, while you're practicing the temporal tap, to actually do the temporal tap while you're both in the ICA and the ECA, just to see what it looks like, because sometimes you might get a little bit of reverb in the ICA, but it should be very prominent like this in the ECA when you're doing the temporal tap successfully. So just keep that in mind if you're ever having a hard time differentiating between ICA and ECA. Some labs here in the United States require a picture similar to this, which is either showing the temporal tap on the ECA, or as you can see in the color box there, a branch artery, right? The ECA has external or extracranial branches. The ICA does not. So if you show a branch, that's telling everybody that, hey, I'm in the ECA here. So it can be helpful when you're doing the exams. So vertebral artery flow. Waveform analysis is probably bigger in the vertebral artery than it is in any of the other vessels, just because we can't fully see the vertebral artery as it goes through the transverse processes of the spine. And so what's important is just to get a good waveform of that vertebral artery to show, is it normal or is it not normal? And what does all of that suggest? Because we can't fully see the vertebral artery. It's a little bit shadowed. And you'll see it in a couple pictures here, but colored flow, cephalad, so it's the same direction as CCA. This is really important to show because the vertebral artery could be a collateral flow for the subclavian artery if the subclavian artery is occluded or, highly stenosed. So there's flow throughout diastole, low resistive flow, spectral flow, low resistive, no reversal. If the flow is present, subclavian steal is suspected. Okay, so if we're seeing any kind of reversal of flow, we should be thinking subclavian steal with the vertebral artery flow. So when I talk about the same direction as the CCA, what are a couple things that we can do to prove that in our exams? One way to prove that is just to get the common carotid artery and fan between the two, the vertebral artery and the vertebral artery, making sure that they're on the same plane, either both going towards the probe or both going away, and show that the color is the same exact for the CCA and the vertebral artery. Another way to show it, if you can, sometimes this is a little bit harder, but when we get the vertebral artery, if we can turn down the color gain, turn down the scale of the color, we can sometimes get that vertebral vein. And if we can show that the vertebral artery and the vertebral vein are going in two different directions, that's another way to show that the vertebral artery is going cephalad and it's going towards the head. If we have high resistive flow in the vertebral artery, we could be in a musculoskeletal branch. There could be a more distal obstruction, most likely more distal obstruction, especially if we know for sure that we're in the vertebral artery. So we lose the end diastolic presence in that vertebral artery because we're feeding a low resistive bed. And if there's a distal obstruction, we're going to lose that low resistive bed and it's going to become higher resistant. Okay, so that could be that's why waveform analysis is huge when it comes to the vertebral artery. If the vertebral arteries are different sizes, sometimes the smaller one can be a little bit more high resistive or completely high resistive flow. So that would be that non-dominant one if it's very clear that there is a dominant vertebral artery. So again, here's a normal vertebral artery waveform. And as you can see, we're only getting, a very, very small part of that vertebral artery itself, right in between the transverse processes of the vertebrae. So low resistive, good acceleration time, good spectral window there. This is a normal vertebral artery waveform, okay? Now, a lot of times you can see here, I don't know if you can see my clicker, but we have a little notch right here in that vertebral artery, okay? This is not hesitant flow when it comes to the vertebral artery, okay? And we'll get to that a little bit later on, but that little notch is not hesitant flow, okay? That's normal vertebral artery flow, okay? Sometimes I've seen that a little confused sometimes with the hesitant flow, but we'll get to that a little bit later here. So we'll talk about pathologies here. So what are a couple pathologies? Atherosclerosis, FMD, fibromuscular dysplasia, dissection, paraganglioma, carotid body tumor, okay? So atherosclerotic plaque may rupture and cause stroke or TIA. It may rupture or it just may break off and cause stroke, TIA in the patient itself. So, right, that's one of the indications that the patient would come in. I had stroke-like symptoms. Ask, how long do the stroke-like symptoms last? Is it still going on? one thing that can happen as well is that the vessel may be completely occluded when it comes to atherosclerotic disease. Okay, so we'll talk about how what the criteria is to say whether or not it's occluded and what percentage of stenosis. Plaque can be described just like Neil was talking about yesterday, right? Homogeneous, heterogeneous, irregular, smooth, calcified. Okay, so those are just kind of the main ways to break down what the plaque looks like in your exam. Again, important for the reading physician to know, well, what do you think it is? Is it new? Is it old? Is it hard to describe? Those are the kind of things that are important, because if it's homogeneous or irregular or maybe even heterogeneous or smooth, very high possibility plaque can break off of those. Calcified, a little bit harder. So just to, make sure we're understanding, what the plaque looks like and describing that to the reading physician. So heterogeneous, irregular, so you can kind of see that in the first picture here. Got a little bit of smooth plaque, and we've got a little bit of calcified plaque showing that shadow there. And then so that would be, described as heterogeneous or irregular plaque, right? It's not the same texture throughout. Homogeneous, smooth plaque in the other picture here, it is all smooth. It's very homogeneous and kind of a little bit hard to see, especially that bottom part is a little bit hard to see there. So that would be described as homogeneous or smooth plaque. And then we have our calcified plaque here. So obviously our sound waves from the ultrasound are hitting that calcified plaque, and we're getting a lot of shadowing distal to those sound waves. And so this can be really hard to actually get a good, waveform in. Is that occluded? Is it not occluded? Let's put our spectral Doppler in there, see if we can pick up any type of flow. Now, a couple things that can help us, identify whether or not it's occluded. And you can kind of see it here. I know this is a black and white picture, but there is color flow, it looks like, distal to that plaque, right? So on the left side of the screen, that is towards the head. And on the right side of the screen would be the heart when we're talking about carotid ultrasound, right? So it looks like there's flow distal to that plaque. So there's probably flow getting through that plaque. Another reason why waveform analysis can be huge with carotid ultrasound is let's put a Doppler distal to that plaque and see what it looks like. Is it a good upstroke? If, what does our window look like? So these are important factors when we're looking at plaque like this that we may not necessarily be able to grade because we can't get a velocity at that point. So another trick would be to put power Doppler on in that area, turn down the gain, turn down the scale, and see if we can pick up any type of flow with power Doppler. So those are just a couple other tricks, and that Leah kind of talked about that in the first presentation there. So color flow, stenosis, right? So with color flow, right, it can help us note whether or not there's presence or absence of flow if we're not calcified plaque. That other one was a little bit tough, right? But in these other two pictures here, we should be able to get good color flow to see, how tight that stenosis is. Is there a color bruit? And more so, where there's a color bruit, that's probably where the highest velocity is. So that's where we need to be putting our Doppler, where we see that color bruit. So it helps us with direction of flow when we're talking about not only the common and the internal and external, but that vertebral artery as well. So color pattern, so we're looking for changes in the saturation or the hue, specifically like I was talking about, that mosaic or mottled pattern that can be at the stenosis or distal to the stenosis itself. So making sure that we put that Doppler in where we're seeing that mosaic to see if there's what the velocities look like, because that may be where the highest velocity is, like I was just saying. It also facilitates the visibility of the tortuosity and the bifurcations. So just kind of, especially in that like distal ICA part of the vessel, sometimes it's really hard to see the walls of the vessel itself. So by putting color on, sometimes it's just like, oh, boom, it lights up and there's the distal ICA. It doesn't mean that there's a stenosis. It doesn't mean it's occluded because we can't see the walls very well. It just means, it's a little bit deeper. It's a little bit harder for that 7 megahertz probe to pick up. So, let's put color on and see if we can see it a little bit distally. And remember that our color flow is based on frequency shift, not velocity information. So it's that shift from one area to the next and not necessarily based off of the velocity. So interpretation criteria. This is really important because every lab is probably going to be a little bit different, but for the most part, they're going to be pretty similar. And this helps, hospital gauge kind of, well, which patient needs to be treated and which patient doesn't need to be treated. And so our higher velocity generally equals a tighter stenosis, right? So when we're looking at a river that narrows, it's going to be faster. That river is going to be faster in that narrowed part, right? So same thing with our vessels, right? Our higher stenoses are going to be higher velocities. Except in the case of like a 95 to 99% stenosis, we may begin to approach zero with our velocities. So it's going to be a little bit on the low end. It's going to be that string sign that Lee had talked about earlier. And then we have, of course, our 100% occlusions, which is our 0 centimeters per second. Vessel tortuosity may cause artifactually elevated velocities as well. So I don't know if you guys remember when Leah had that tortuous carotid artery on our screen, right? But on those areas of the turning points, that's where there's going to be some higher velocities. So when we're grading a stenosis, it's really important, right, that we're treating patients, not pictures. So make sure that we're seeing plaque with our elevated velocity. Okay, we're not just going to be taking pictures of high velocities. We're going to make sure that we visualize the plaque with the higher velocities. And so that can help you differentiate between tortuosity and actual stenoses. We also have our ICA-CCA ratios. These are important, and we'll get to that when we get to the case studies. There's a specific case that I want to talk about with the ICA and the CCA ratio. But we're going to take the highest ICA peak systolic velocity and either our mid or distal CCA peak systolic velocity to get that ICA CCA ratio. I highly suggest to take the mid CCA peak systolic velocity for the ratio. I think that gives us a better understanding of what actually is going on in the CCA. If you get a little too proximal, right, we're getting closer to the heart. We're getting close to that bifurcation coming off of either the brachiocephalic or the aortic arch if we're on the left side. So you can get a little bit, wonky of waveform with that. And if we get a little more distal, we get closer to the bifurcation of the ECA, ICA, and sometimes that can create a little bit wonky of a waveform as well. So that's why I kind of like to take that mid CCA peak systolic velocity for our ratios. The higher the ratio is usually consistent with a tighter stenosis, right? So if our ICA is high, and our mid CCA is pretty low and we get like a 3.0 ratio, right? That's consistent with a stenosis, most likely. But again, important to visualize plaque with those higher velocities in the ICA. It is unreliable, and most of the criteria is going to be unreliable if there is significant common carotid artery plaque. Okay, so if we're seeing plaque within the CCA, our ratios, our velocities, they're all going to be thrown off because we're going to have dampened waveforms distal to a tight stenosis. So if the tight stenosis is happening before the ICA, then our velocities are going to be thrown off in the ICA itself. And it may be more helpful than velocities in patients with low cardiac output, right? So if we're getting low velocities going into the common carotid artery, right, we're going to still have low velocities into the ICA. So if we're, at 20 centimeters per second in the common carotid artery and we're 100 centimeters per second in the ICA, we have a ratio of 5.0. So therefore, it may fall into more of a category of a 70% stenosis or 50 to 69% stenosis. Really kind of hard to differentiate between the two when we're only get a velocity of 100, but the ratio could tell us that there is a stenosis if we're having low cardiac output. Okay, so this is the consensus criteria they updated for the IAC for accredited vascular labs here in the United States. So 180 is gonna, I just kind of want you to focus on that number here. The 180 centimeters per second is going to be the cutoff for our normal, our less than 50 compared to our 50 to 79 or 69. So if we're getting a velocity within above 180, all of a sudden we start hitting that 50% stenosis. And at that point, that's when we talk about that 50% mark. That's our our hemodynamically significant stenosis. Yep. So that's why we have that 50% mark there at 180. And then when we hit that 230 mark, all of a sudden we're getting close to that 70% stenosis or more. And obviously, here's our ratios over here on the additional parameters. So our ICA-CCA ratio, anything less than 2 is going to fall into that normal or less than 50% category. All of a sudden, we start to hit 2 with our ratio. We're looking at that 2 to 4. So when I was talking about that 20 to 100, that's that 5.0 ratio. So now that's what I was talking about as far as the greater than 70% stenosis. And then anything above 4.0, like I was just saying, is that 70% stenosis. So ratios can be important when, like we were talking about earlier, right? When we have low cardiac output and we're having low velocities within the common carotid artery. And then we have our near conclusion, which is that string sign that we were talking about. So we can visualize plaque. We can visualize very little flow getting through the carotid artery, but we're getting low velocities, which is that approaching 0 mark. And our ICA and ratios, our end diastolic velocities are going to be variable. They're probably going to be lower than what we're seeing over here. And so they're still near occlusions, okay? Just because they don't meet any kind of velocity criteria, they're still critical stenoses. And then we, of course, have our total occlusions, which we have no detectable color, no detectable waveform within the carotid artery itself. So interpretation of this, right, stenosis may be classified as follows, right? We have our mild, we have our minimal. Anything less than 50% is going to be a mild carotid stenosis. So when we talk about mild, we're talking about there is plaque there, but it's minimal. It's less than 50%. We have disease present. It does not restrict flow, or there's little to no velocity increase. So everything below that 180 mark that we were talking about earlier, right? Our disease is present, but it's not restricting the flow. It's not hemodynamically significant. This is typical that it does not embolize when it's at this point here. So you can have soft plaque. You can have all different kinds of plaque that are easy to break off. But when we're not seeing any elevated velocities, it's not likely to embolize. So it doesn't mean that we don't follow up on these patients, but suggestive of following up annually, because plaque can build on itself and eventually it can create a hemodynamically significant stenosis. So still needs to be followed up on if we have mild or minimal disease, okay? So important in our exams, right? And important when we're talking about or putting in our worksheets, whether it's less than 50% or whether it's 0%, okay? If it's 0% and there's no plaque, there's probably no need to follow up. But if you're seeing plaque, that's still important to note. So again, here's a mild stenosis. And as you can see here, we have some soft plaque. We actually have a pretty good amount of stenosis as far as like the area itself reduction, but we're not seeing any color bruits. And so therefore, we're probably not getting high velocities within that. So here's longitudinal, here's short axis. So here is another kind of, I don't know, you could almost call this heterogeneous, but it's pretty smooth plaque on the right side there. A little bit less of a diameter reduction. So again, mild stenosis there. So just because you might measure it doesn't mean that there's elevated velocities, okay? We're not the gold standard when it comes to measuring diameter reduction. That's CT, but we rely a lot on the velocities. So interpretation of the moderate stenosis here, right? 50 to 69%. So we're all of a sudden we're above that 180 mark. Okay, we're in that 180 to 230 centimeters per second. Okay, and we're in that 40 to 99 centimeters per second as far as our end diastolic velocity. We have disease present. The patient may be in because they had symptoms. So you're seeing increased spectral broadening in that case. So anytime we have a stenosis, we're going to be seeing spectral broadening. And then again, we'll need to follow this up annually because at this moderate mark, it probably doesn't suggest surgery still at this point, okay? So this is a hemodynamically significant stenosis, but this again is going to be followed up. It's not going to go directly to surgery to take care of it, okay? So we'll need to continue to monitor this patient as well to see if it increases into that greater than 70% stenosis. So again, here's some pictures of moderate stenosis, right? We're seeing that mosaic, that mottled kind of appearance, and where you're seeing the color bruise, which is where the blue is in the pictures. That may be where you're going to be getting the high velocity. So putting color on can help you identify where you need to put the Doppler. So now we have our severe stenosis, our greater than 70% stenosis, okay? So we have abnormally high velocity. So now we're getting above that 230 mark and we're getting above 100 in our end diastolic presence. Our ratios are now above 4.0. We have extensive plaque at this point, probable calcifications, right? So when we're talking about following up, say, less than 50% stenosis or a 50 to 69% stenosis, we're going to be following them up annually. And if they end up in that 70% range, it's probably going to take years to get to that point. And as Neil alluded to yesterday with DVT, same thing goes with carotid plaque. Okay, the longer that it's in the body, the more it's going to be calcified. So probably it's going to be a calcified plaque. Velocities may approach zero if it's critical, like we had been talking about, and maybe string sign. Again, power Doppler is your friend. Turning the gain down, color gain down, turning your scale down on your color is going to help as well. Occlusion, obviously, no flow. So you've confirmed that we have no flow within the carotid artery, and we'll have a few pictures here to show it. So here's our severe stenosis. So in that first picture here, we're getting velocities of 598 centimeters per second over 314 centimeters per second. And then we're getting post-stenotic turbulence as well, distal to that stenosis. So that's what you kind of see in those bottom two pictures. And then we have our ratio of 10.87. Okay, so obviously higher than that 4.0 mark. So whenever we get a stenosis, it's important not only to find that elevated velocity, but then especially in this picture here, showing our post-stenotic turbulence within the waveform itself, okay? So important to get the stenosis, get the post-stenotic turbulence as well. And then here's our critical stenosis. We have our string sign here. And then we turned on power Doppler in the bottom picture. And these are our low velocities, right? So our proximal ICA, where that first Doppler is 84 centimeters per second, and that mid to distal part, it's dropping to that 28 centimeters per second. So again, we're approaching zero, okay? So it's not that 230 centimeters per second. It's not 500 centimeters per second, right? But it's still a critical stenosis. It's probably greater than 95% at this point when we're seeing that string sign. So again, colored power Doppler can be our friend in this case. And so that greater than 70% stenosis, these are all going to be candidates for surgery. So. Again, here's our occlusion now. So not string sign, we have our occlusion. Okay, so we've turned power Doppler on, we've turned our scale down, we're still not getting flow. And you can kind of see in this waveform here what we call this thump artifact. Okay, so you're just seeing kind of those velocities hitting the plaque on the proximal end of it, and it's kind of vibrating throughout the plaque. So that's just that thump artifact. Okay, it's not a waveform, it's a thump. And so that can also be an indication that it's occluded and not string sign. So another kind of term you might hear with string sign is functionally occluded. It just really means that it's essentially occluded. But same exact thing as the string sign, is that there is flow and it's not fully occluded, it's just functionally occluded. So if you ever hear that terminology, that's kind of what that means. So flow reversal. Flow may reverse in cases of significant stenosis or occlusion. So specifically in the vertebral artery in the case of subclavian artery disease. So we were talking about that earlier. The ECA can reverse and feed the ICA if the CCA is occluded. I've never seen this in the field myself, but I know that it can happen. And I've heard other people present on it and have seen it. The ECA can reverse and feed that ICA if the common carotid artery is occluded. So just keep that in mind. And it's really important, again, to understand what direction of flow that it's going. So color box, making sure that everything's going towards the probe the way that it should be going towards the probe and away from the probe as it should be. So if we have, so for the vertebrals, right, reversal flow, subclavian steel. So we're going to kind of go through the different types of waveforms. We have our normal vertebral artery waveform that I showed earlier. Then we have our hesitant waveform, our pre-steel kind of waveform. And then we have our alternating or our two-fro flow, bidirectional flow. Leo was talking about our bidirectional flow earlier. And then we have our reversed flow. So it's completely reversed and it's a complete steel at this point, okay? So that first picture here, that is our hesitant flow. And you can kind of see here's the rabbit ears, here's the rabbit body. So hesitant flow here, we got that big dip in that spectral waveform. And then we have our alternating, our two-fro flow, or the bidirectional flow here in this picture. And then we have our complete reversal of flow here. So this is complete subclavian steel. Again, you can see that we aren't getting full, color flow, full picture of that vertebral artery. That's why waveform analysis is important with the vertebral arteries, okay? So we have our fibromuscular dysplasia. So this can be another disease process. So typically, and Leah talked about this earlier, is that when we have atherosclerotic disease, it typically happens at bifurcations. Okay, so that's why we see a lot of carotid artery disease, internal carotid artery disease in the proximal artery itself. Okay, if we're getting elevated velocities distally, it may suggest that there is fibromuscular dysplasia. Okay, this is a problem more in the renal arteries itself, but it can be found in the ICA, specifically distally, like I was talking about. So it's known as the string of beads effect in a radiographic appearance. Okay, but if we're getting high velocities distally, let's get a really try our best to get a really good color picture of it to see, well, is this FMD? FMD typically occurs in females about middle-aged, and it may lead to spontaneous dissection of the ICA, right? Because it is it's an issue with the wall of the artery itself. Lesions are usually found mid-distal, like I was talking about, and it's difficult to visualize in beam mode, but once you turn color on, it can be a little bit easier to see. It can extend all the way into the skull itself, but it rarely affects the intracranial vessels. So again, if it's distal, we're getting elevated velocities, let's turn on color and see if we can see that FMD. So the string of beads effect may be difficult to appreciate on ultrasound itself. A lot of times it's easier on a CT scan, but we're seeing sudden turbulence in that mid to distal ICA, right? So Plaque usually happens in the proximal part, so if we're seeing something distally, could be this. And especially if we're not seeing any like waveform changes itself too much in that proximal ICA. So again, you're seeing color aliasing here, and again, we're getting higher velocities, but there's no atherosclerosis disease seen proximally to this point. So carotid dissection is another thing we can see. So trauma usually occurs with carotid dissection itself. Cross-chest seatbelts, motor vehicle accidents, blunt trauma, chiropractic manipulation. Sometimes I've even seen this where a patient simply sneezes. Now, a lot of times the patient itself can't identify in the case of the sneeze that it's that's what caused it. So a lot of times sneezing with a dissection is usually spontaneous dissection, not associated with either of the above, because spontaneous means that the true cause is simply not known, although they can commonly begin at the aortic root itself. So sometimes when you're seeing it in the carotid artery, you can actually see the entire internal common carotid artery all the way down to the aortic root be dissected. I've seen it all the way down the aortic root and into the distal aorta, all the way into your abdomen. So dissections can come from can be extremely long, and they can come from the aorta itself. So important to know with a carotid dissection, what is the true lumen and what is the false lumen. So making sure we're using our waveform analysis, putting our spectral in both sides of that dissection itself, and seeing where the normal flow is. So like atherosclerotic disease, this can cause TIAs or CVAs. Some are atypical though, so you can get a headache, some combination of symptoms, unilateral headache followed by delayed cerebral ischemic symptoms. You can get severe neck and scalp pain, sudden onset of cessation or bruit, or Horner syndrome. So Horner syndrome is just characterized by the drooping of the ipsilateral eyelid itself. So Horner syndrome, a little bit different than amaurosis fugax. But surgical reconstruction is probably going to be done at this point, because once we have a trauma like this itself, that can cause stroke. So it doesn't mean that there's a significant stenosis. It just means, but it can still cause strokes. And so the surgeon is going to probably want to repair this dissection sooner than later. So let's talk about carotid hemodynamics, okay? And I know that all of you are muted, but if you want to put it in the chat, or if you just want to wait for me to kind of give the answers, you can. But if we're seeing this in our CCA, so now let's apply our waveform analysis to some case studies. So first, we're seeing this in the common carotid artery itself. Where is the obstruction? Okay, so it doesn't mean that there's total occlusion, doesn't mean that it's partial occlusion. I'm just asking where most likely is the disease. If we were to put our spectral Doppler right in the mid, let's just say mid or even proximal CCA. I'll give you a few seconds here to kind of think about it. So when we're looking up at our waveform analysis, right, let's look at upstroke, and let's look at what our end diastolic presence look like. I really like, when I'm looking at waveforms itself, to break it down into two different sections, right? I like to draw a line right where the peak is, right down the peak, and everything on this side of that waveform is going to tell us what's happening before that point, and everything that's on this side of the waveform is going to be telling us what's happening downstream. So what we're seeing here is we're seeing a delayed upstroke. We're seeing monophasic flow, even though it's low resistive. This is an abnormal waveform in the CCA. Something is happening more proximally, right? Something is either happening right at the origin of the CCA, yeah, or it's in the aorta itself. If we're on the right side, could be in the innominate artery. So just keep in mind, yes. So all of you who put proximal occlusion or proximal disease, it is proximal to that point when we're talking about that delayed upstroke. Okay, it's not a good acceleration time. It's a bad acceleration time. So if now we put our Doppler right in that CCA again, and we're getting this waveform. Okay, so where is the obstruction in this case? Give you a few minutes to kind of think about this. Again, what is our acceleration time? What is our normal common carotid artery waveform, and what does it look like as far as high or low resistive? Yeah, good. Distal to that CCA would be the correct answer. Specifically, what I would think in this case, if we were to get this waveform in our common carotid artery, I am thinking that we're having both ECA and ICA, probably occlusions. And the reason why is because if that ECA were open, we'd probably still have some end diastolic presence. Okay, it might still be a little bit low resistive here. So this could possibly be both ECA and ICA, or very, very distal CCA. All right, let's go to our next one. All right, so we have ICA origin waveform here, okay? Let's pretend that the peak systolic velocity is somewhere in that 60 centimeters per second range, okay? So what are we looking at here? Where again is going to be our obstruction in this case? So when we're looking at that acceleration time, right? So I'm kind of seeing a really bad acceleration time. Okay, so I'm thinking more proximal again at this point. It's very, very possible, and Leah talked about it a little bit in her first lecture. It's very possible that we're right at the bulb and we're getting a whole bunch of mixed velocities as well. This may be normal in the bulb itself in the ICA origin. I'm seeing a delayed upstroke, so I'm assuming more proximal disease. But let's take a waveform distal to this point, maybe in that proximal ICA, maybe in the mid ICA, and see what that acceleration time, what that waveform looks like in the mid CCA. Okay. All right. So now we're going to the vertebral artery. Okay. So we're going a little bit posterior. We get this waveform in the vertebral artery itself. Okay. Where are we thinking that the obstruction is? What does a normal vertebral artery waveform look like, right? Is it high, low resistive? What does the acceleration look like in this waveform? Those kind of things, right? So in that vertebral artery, we, we're getting this waveform. We're looking at a more distal obstruction, either in that vert itself or in the basilar artery, right? Because the verts come together to form the basilar or basilar artery. Important to note, what does both vertebral arteries look like? What do both vertebral artery waveforms look like? If one is normal and the other one looks like this, probably just in that vertebral artery. If both of them look like this, probably in that basilar artery. All right, so we put our Doppler in that vertebral artery again. We're getting this type of flow. All right. So looking at acceleration time, thinking about what is our normal vertebral artery. So this would be classified as our hesitant flow, right? We're getting the bunny ears, we're getting that bunny in the waveform. So as soon as we see something like this, we are thinking subclavian steel. Okay, so we're thinking on the right side could be some kind of subclavian artery flow, brachiocephalic, or on the left side, subclavian. So keeping that in mind, right? Seeing this flow, thinking subclavian steal, right? Yeah, we have some type of reversal of flow. Well, it's not necessarily reversed in this case, and we can't see anything below the baseline, but this is kind of like our pre-steal flow. So we get this waveform in our vertebral artery. Where are we thinking the obstruction is? And we 100% know that we are showing that this flow is going reversed. So now we have reversal of flow. Again, this is full steal. This is full subclavian steal, meaning that we have significant subclavian artery disease. So like I said, let's look at some waveforms when it comes to cardiac abnormalities. So they can alter the arterial waveforms themselves in the carotid artery, most likely seen in that CCA. And they may vary depending on the severity of the cardiac disease itself, okay? And I'll quickly kind of go through these just because what I want you to note more than anything is that there can be wonky waveforms without there being carotid artery disease itself. It doesn't mean that you have to diagnose it and put it in your report, but just keep that in mind as a tech. So we have kind of like that dampened waveform. We have like that, we kind of have a quick acceleration time and kind of a rounded kind of peak of it. Some people may say that that's a good acceleration time. Some people may think it's not. But this could be the case of an aortic valve stenosis when you're looking at this waveform itself. So again, still kind of something that's happening proximally, but it can be a wonky waveform. It doesn't necessarily mean that there's disease in the arteries itself. So aortic valve insufficiency, right? So we have reduced or retrograde diastolic flow. It just simply means, right, that we're not pushing enough blood out of the heart. So we get kind of low velocities, we get low cardiac output, we get reduced or retrograde diastolic flow. Another kind of form of this is that kind of bisphareous pulse. So we have our kind of a two systolic peaks, okay? So sometimes you'll get this. It just means that you have the aortic valve insufficiency. It doesn't necessarily mean that we have carotid artery disease. Aortic valve stenosis, again, we're kind of getting that prolonged upstroke, that dampened peak, that reduced or retrograde diastolic flow, okay? So carotid intervention. So when we're talking about, whether we're talking about dissection or FMD or atherosclerotic disease, endarterectomies mainly take place right when we have atherosclerotic disease. Stents or bypasses could, be placed in these patients who have any of the above: atherosclerotic disease, dissection, FMD, those kind of things. So let's get to a little bit more in depth with our case studies here, okay? So we're getting close to the end here, I promise. But let's keep in mind what our IAC criteria is, the updated IAC criteria. So if we're in our ICA here, we have a peak systolic velocity of 524 centimeters per second and an end diastolic velocity of 200 centimeters per second. What is our percent stenosis based off the criteria given here? I'll give you a few seconds. You can put it in the chat if you want, or you can just wait for me to give you the answer. So again, where is our normal velocity supposed to be? Right, so pretty clear that this is a greater than 70% stenosis, right? So we, without even getting our ICA-CCA ratio, we are having that greater than 30 centimeters per second as our peak systolic velocity. We have more than 100 in our end diastolic velocity. We have a ratio greater than 4. Most likely, this is, like I said, this is without it, but I'm guessing that our ratio is probably going to be more than 4. And it wouldn't be near occlusion, right? Because we're not getting that string sign. We're not getting velocities close to 0. we're still getting high velocities in that 500 centimeters per second range, but still very, very severe stenosis. All right, so this is one that I want us to kind of think about here. So in our right, we get a right mid CCA peak systolic velocity of 30 centimeters per second with spectral broadening. Okay, we have a right proximal ICA peak systolic velocity of 98 centimeters per second with an end diastolic velocity of 40. Okay, we have significant plaque that we see within the ICA itself, and we have an ICA CCA ratio of 3.7. I want you to grade this stenosis. All right, I like what I'm seeing in the chat here. Okay, this is a tough one, and simply because of that CCA being 30 centimeters per second with spectral broadening, we kind of almost can't grade this. So we can't specifically say that there's a 50 to 69% stenosis. I really like, though, that you guys were looking at that ratio, okay, that 3.27 ratio, which falls in that 50 to 69% stenosis, okay? That can indicate, and you can even put it in your report, I'm seeing significant plaque. Our CCA, ICA CCA ratio is 3.27. However, the velocities may not suggest um, at 50 to 69% stenosis due to more proximal disease, and more proximal disease meaning that right CCA. So as soon as you're kind of starting to see that and the velocities, you kind of almost have to throw the criteria out the window. But yes, please keep in mind that 3.27 ICA CCA ratio. It can help us distinguish whether or not there's significant plaque without our velocities meeting the criteria. Okay. However, I would hesitate myself to say that this is a 50 to 69% stenosis for sure, okay? But that our ratio may suggest significant stenosis with the visualization of significant calcific plaque, okay? So just want to keep in mind that can help us. This can be a case that pops up and one that's hard to grade. So just want to keep that in mind. So let's talk about kind of a minimum protocol for a carotid ultrasound. So like I said, I really like for our ratios to get that mid CCA ratio. So that's why I have that mid spectral waveform with velocity measurements in that CCA. So let's get a transverse or long axis picture first of our ICA, ECA. Then we'll get that kind of mid spectral waveform with velocity measurements. Okay. We'll get a proximal ECA waveform with velocity measurements, a proximal ICA with velocity measurements, and then a spectral waveform with velocity measurements in the vertebral artery. So note, though, that if you get increased velocities in that ECA, usually somewhere around like 200, 180, anything above that, just make sure we're taking our post-stenotic turbulence picture. Same thing with the proximal ICA. If we're getting increased velocities, let's take a second picture to show increased velocities itself. So when we see disease, make sure we're taking a lot of pictures of that disease itself, whether it's B mode, whether it's color, and making sure that we're taking the post-stenotic waveforms along with that elevated velocity waveform itself. So like I said, this is a minimum protocol. So as long as we have a lot of these aspects in our protocol and in our exam, hospital to hospital, we can at least kind of grade what percent stenosis and be consistent in our scanning. So these are just kind of the important measurements, or especially if you're on a time constraint and you just need to, the patient has something going on, or you have a lot of patients to get to. These are the important things to note for our vascular surgeons. What making sure we can get our ICA-CCA ratios and making sure that we're taking velocity measurements in the proximal ECA, ICA, where most likely plaque is going to occur. And then, of course, taking that velocity measurement and a spectral waveform in the vertebral artery to make sure that that's normal as well. So, like I said, this is the updated IAC accredited criteria for internal carotid arteries. So remember, this is internal carotid arteries, not external carotid arteries. This is internal carotid arteries. This is what IAC suggests now to go along with your minimum protocol that I had put up. So thank you guys very much. I hope I wasn't speaking too fast. Really appreciate you taking the time to be here today, and hope that this helped, or hope that at least this got you thinking about certain things as well. So thank you.
Thank you, Ethan. Dear Lizette, if you can please stop the recording.